Welcome to Patients at Risk, a discussion of the dangers that patients face when physicians are replaced with non physician practitioners. I'm your host, Dr. Rebecca Bernard. Today, we're going to talk about a call from the Center for Disease Control for public comment regarding allowing nurse practitioners and physician assistants to read special x rays that are done on workers who are at high risk for problems caused by inhaling substances during their work. For example, people that work in coal mines or work in different factories where they may be breathing small fragments of dust or other particles. Today, we are talking with a physician who wrote some public testimony to the CDC about his concerns about allowing non physicians to do this type of work.
My name is Gary Dudek. I practiced pulmonary medicine and critical care medicine beginning in 1991 through 2020. And during that time, I did interventional bronchoscopy, I did surgical intensive care, I did medical intensive care, and most of the time I was actually in combined medical surgical intensive care units as well as a general pulmonary practice, outpatient practice.
So, you know a thing or two about pulmonary disease. So, that is why I wanted to have you on to talk about a new program that the CDC is looking at, which is to expand the reading of x rays for a particular lung condition from just radiologists with special certifications to nurse practitioners and physician assistants. Now, this program is called the B Reader Program, and it's through the National Institute for Occupational Safety and Health, which is NIOSH, that's the abbreviation. And what it is that some physicians are certified to read chest x-rays looking for pneumoconiosis. Can you tell our audience what pneumoconiosis is?
Well, pneumoconiosis is a type of interstitial lung disease, meaning that it affects the very fine lung tissue itself, and it's caused by the inhalation of inorganic dusts, such as silica being the most common.
And I think in this case, we're mostly looking at like coal workers. Is that accurate?
It is. So the patients that I have seen with pneumoconiosis primarily were coal workers from Pennsylvania or West Virginia. And I've seen other patients who are followed with chest x-rays who work in such industries as glass recycling plants where the glass is actually crushed. And so the glass becomes a fine powder that could potentially be inhaled. And they are also followed for the possibility of silicosis.
Right. I do see that here about these x-rays are done usually in workers with jobs having exposure to mineral dusts such as coal mine dust, crystalline silica, and asbestosis as well.
Right.
So it's something that they do as screening, or if they are symptomatic.
It is screening, and it's generally mandated by NIOSH to be a chest x-ray once a year that is then read by a B reader looking for early evidence of interstitial lung disease related to their occupation.
So basically, people that work in high risk jobs where they may be breathing in these particles are therefore required to undergo an annual chest x-ray looking for evidence that they are developing this condition. Is that right?
That's correct.
And if they are seeing these signs, then the next step is special precautions, or do they have to stop doing this kind of work?
Well, that's sort of the crux of the issue. The decision is not made by the B reader per se. The decision is often then passed on to an occupational medicine physician with the knowledge of the B reader's interpretation of the chest x-ray. They either make the decision that, yes, this is truly early interstitial lung disease and the patient needs to be removed from exposure to that dust, or they pass the decision on to a pulmonary consultant, is often what happens.
So there could be some politics or some, kind of conflicted interests here because you have the worker who has to do the x-ray who may want it to be normal so they can keep working, or if they're starting to get sick, clearly they're going to want to know that sooner than later so that they can avoid further exposure to this. And I'm assuming this is a potentially fatal disease.
It is. Um, and even in coal workers' pneumoconiosis, the silica in the granite that they're chopping through to get at the coal is really the culprit of the lung disease. And silicosis, if you catch it very early on, it's termed simple silicosis, in which very tiny nodules are seen in the lung. They're never going to go away, and they may progress. And when they progress, these nodules tend to fibrose together and pull the lung tissue into a big scar called progressive massive fibrosis. And that's the stage of disease that is very symptomatic. Um, Lots of shortness of breath, often hypoxic, coughing constantly, producing a lot of mucus, and it tends to be inexorably progressive and ultimately take their life.
So this is super serious. We need to find and diagnose this very early so that it doesn't get to that serious and
Correct.
symptomatic and potentially life-threatening stage. So you
Right.
have the worker that, of course, is interested in their health and, of course, their profession. And then you probably have the employer or the company that might want their workers working as long as possible. So do you see that that could create any kind of conflict of interest when you're
Oh,
looking at this?
absolutely. Big time. And also, the employer is sort of on the hook for paying medical expenses for people who are diagnosed with this condition. So they have a vested interest in not finding it. The workers often are conflicted because it may be the only job in town, essentially, that they can do. So they don't want to lose the job. On the other hand, they don't want to die as a consequence of their job either. So they can have very mixed feelings about what to do.
So this is a tough situation, and it is important in the sense that someone's life may be resting on the balance of how this chest X-ray is read and interpreted.
Yes, I agree.
And in fact, up to this point, the only people that are allowed to read these X-rays are certified what they call B readers. And would you say that's usually going to be a radiologist?
In my experience, it's always been a radiologist. And the B readers that I have known have all been clinically experienced radiologists who subsequently took the course in B reading to become certified in producing the reports appropriate for a B reading. And the ones that I've talked to have, it's difficult for them. I mean, finding these early signs of interstitial lung disease is very difficult, even for an experienced radiologist. And they're also sensitive to the fact that they don't want to overcall something that may not truly be there and entrain a whole series of workup that may not be necessary and may be injurious to the patient's job in the process.
Yeah, it sounds like it's a very difficult thing to do. And, especially considering that radiologists go through so much training to be able to be a radiologist. It's 4 years of medical school, and I think it's 5 years of residency, if I'm not
5 year resident.
mistaken.
That's correct.
And then even that is not enough. They still have to go through this special training to be a B reader, and they have to take a pretty rigorous examination as well. So it seems like the CDC believes that there's not enough radiologists or not enough B readers to read the X-rays. So what they've decided to do is investigate whether or not they can let a non-physician, non-radiologist, nurse practitioner, or physician assistant become a B reader and make these decisions about a patient's life or death. What were your thoughts when you heard that?
Well, my concern is that I have worked with physician extenders my entire career. And it began shortly after I finished fellowship. It was a situation in our ICU where we lost resident coverage and needed to enlist the help of a nurse practitioner, a newly minted nurse practitioner, but one who had critical care experience of 10 years before she did her nurse practitioner training. And it worked out tremendously for us. And since that time, I couldn't imagine ever practicing in an ICU environment in which I didn't have the help of either a physician assistant or a nurse practitioner, because the ones that I knew being a nurse practitioner or physician's assistant were second careers for these people. And their first careers had always been related to patient care, either in emergency departments or ICUs or as respiratory therapists. So they were familiar with dealing with patients who were in crisis and became very good at it. But having said that, there isn't a one that I've ever known, even those with 15 or 20 years of experience, that felt comfortable reading a chest x-ray by themselves and making important decisions on that chest x-ray. And if things were to happen in the middle of the night and chest x-rays were required, those chest x-rays were always reviewed at least with the emergency room physician before they'd even call me about what was going on. So I've also had the opportunity to teach in a physician's assistant training program over the course of 4 or 5 years. And so I'm kind of familiar with the training that they received. And none of it comes close to the type of radiologic teaching that I experienced in medical school and then through 3 years of residency. So they just do not have the background to be able to do those interpretations. And I fear several things. One is undercalling disease, which is there because they don't have the ability to really see the early interstitial changes that may be present. Another concern would be to be overcalling changes on the chest x-ray that are unrelated to interstitial lung disease. And the third is, if a radiologist is doing a B reading and they see mediastinal lymphadenopathy, but not anything that would be attuned to the B reading itself, they're still going to read that and call it as an abnormality and bring it to somebody's attention, which may have nothing to do with their occupation, but may be a serious medical condition. And I fear that those people are going to slip through the cracks if the x-rays are not reviewed by somebody with clinical experience.
Ultimately, it just seems like it's a really poor idea. Do you think it's stemming from not enough radiologists that want to
Yeah.
be B readers? What do you think the problem is coming
I
from?
think it's entirely a manpower issue. It's the same thing with staffing ICUs. They're all a manpower issue.
One of the comments from a Dr. Martha Kearns that was posted publicly to the CDC's website was that the CDC has indicated they need more B readers, but there is currently a single annual in-person course which teaches the skills. So they say if you need more B readers, why, instead of looking at NPs and PAs, why don't you actually try to help radiologists get those skills and make it easier for a radiologist to become a B reader and make it more affordable? Because I see other comments saying people didn't want to keep up the B certification because it was expensive.
Correct. Yeah, absolutely. And I
So it sounds
believe,
like there's easier solutions than looking outside for people that have no qualifications to do this.
well, I think it all, again, boils down to the fact that there probably are not enough radiologists to handle the current volume of work just with plain chest x-rays and CT scans for lung cancer screening and so forth. The ability to screen for disease using radiologic technology has increased their workload by orders of magnitude. But the numbers of radiologists trained ultimately to deal with this, I don't think has at all kept pace with the excess workload.
Yeah,
Um,
and not only the screening, but also the number of non-physicians ordering x-rays has increased, not so much from doctors, but the data that I've seen shows a huge number of x-rays and imaging tests being ordered by non-physicians, something like 440% higher in one of the studies that I reviewed for the book.
it's interesting. I don't doubt that. And I spent the last 6 years in practice in a rural community in which patients often came in as having been assigned to a particular primary care physician whom they had never seen, even though they had been in the practice for 10 years or more and had always seen nurse practitioners primarily or physician's assistants. And what was even worse is they seemed to never see the same one twice. So there's no longitudinal care or experience of providing some type of therapy and then following up to see the result of that therapy, they'd be seeing somebody different the next time. And the result of that, from my perspective, is just a boatload of referrals for consultation. That probably, if this person was referred back to the internist, 50% of the time that could have been curtailed. But the primary care docs were overloaded with their own panel to the point that they couldn't possibly supervise the nurse practitioners or physician's assistants with any depth at all. A manpower shortage, again, I guess, is what we're getting to.
It's kind of a vicious cycle. You have overburdened primary care now using NPs and PAs. They then refer to specialists more often. Now the specialists are getting burdened and they hire an NP or PA to help them out. And you see it just spirals out of control. And to me, as a primary care doctor, it always comes back to investing and having more robust primary care and preventative care services, which I guess takes us right back to the B rating because this is about prevention and screening. And
Correct.
we really need to invest in the properly trained people. We need to give them the right training, the tools, the time to do it, and the proper motivations because usually prevention is not as well compensated as more aggressive intervention treatments in our system.
That's correct. It might be a bit of a different story if the task ahead of these people was an easy one. But to be a B reader is extremely difficult for a trained radiologist, let alone somebody who has no formal radiologic training. It just doesn't make sense to me. I hope some rational thought will supervene and perhaps limit the scope of practice for nurse practitioners so that they are truly in a monitored setting so that they can take an x-ray to a physician and ask them questions about it and not rely on their own interpretation for which they have no training to be able to provide that interpretation.
Yeah, studies show overwhelmingly that when nurse practitioners and physician assistants work under physician supervision closely together, patients can get great care. But when you take the
Absolutely.
physician out of the equation, then we just don't know. We can only speculate, but you would think using logic, if you have a fraction of training and experience, the outcomes are probably not going to be so good.
Yeah, and it significantly deviates from how I grew up incorporating physician extenders into practice in that, if a physician extender saw a person for an acute visit, I mean, at least the rules in our office were, okay, you get 2 cracks at it. You get 2 visits. If things aren't on track after 2 visits, it's got to come back to a doc. And things have totally derailed from that type of practice, which I think has led to a lot of the excessive consultations, excessive radiologic tests requested, excessive blood tests requested, and no net benefit to the patient as a consequence of all that.
Like a lot of initially good ideas, there's unintended consequences, and if things aren't carefully monitored, it goes off the rails. And I think that's exactly what we're seeing right now.
Right. And I can understand from the other side. I worked in part in a county that had, I think, 3 internal medicine doctors to cover the entire county. And so the powers that be, mostly the employers in the area, just wanted some body to be able to serve as a medicine link for the patients to be able to at least gain access to the medical system. But to provide that link as, for example, a nurse practitioner who practices by themselves, I think led to very problematic medical care, which ultimately would end up in the specialist's office, sort of many months, if not a year or more down the road from the initiation of whatever the problem was that began. Wasted time, wasted dollars, wasted tests. So ultimately, we as a society bear the cost of that waste. And the good physician extenders that I worked with throughout my entire career would never want to be out there by themselves. They'd be scared to death to do that because they've learned what they don't know. uh,
Exactly.
and are scared to miss what they don't know.
I think it's more the lobbying organizations and the advocacy organizations are kind of pushing that direction
Right,
because I agree with you. I'd say many people that I speak to say, I don't want to do this. I want to work with a doctor,
right,
except for people who don't know because they've never really seen anything scary or bad. So they don't
right.
realize what could happen.
Yeah. And from a financial standpoint, they're cheaper to hire, they're cheaper to train. And that I think is what's driving the whole process.
It really is a very short-sighted way, but sort of the way we do things sometimes we're not really thinking long term. We're just thinking about,
Short term.
how to deal with it right now. And especially if we're having a health care system that is being run more and more by corporations, including private equity, the priority number one is making money or saving money.
Right. Even for non-for-profit organizations that I worked with, you know, the the drive was to maximize profit. And as physicians retired, they weren't replaced by physicians, they were replaced by nurse practitioners. And that just led to a significant degradation in the quality of medicine that could be provided to the patient population.
Do you feel a little nervous about, you're retired now, and of course I always say I'm a patient, I will be a patient, and we'll all be a patient. Do you get a little nervous about the way the system is going?
Absolutely. Absolutely. I wonder who will be around to take care of me when I can't sort of speak for myself should that happen or have somebody to advocate for me. So it is scary. I mean, there are and NPs that I've known that I'd want to take care of me in the ICU because they know their limits and they know when to ask and who to ask and get the right database upon which to treat me. On the other hand, I've also known physician extenders who thought they knew it all and didn't want to hear from anybody as to their recommendations for how to treat patients. And those folks are dangerous. And it unfortunately won't become real to them until they make fatal decisions.
Right. Well, that's why we have to speak out, and hopefully someone's listening. And I think it's going to take somebody in power and importance. Unfortunately, I fear that something bad has to happen, like somebody important has to be harmed by this before anyone will take action. I hope that doesn't happen. I hope that the powers that be will take heed of this and start to make some change to protect not only patients, but like you said, society, because it does have repercussions
Yeah.
for all of us. Thanks so much for listening to this podcast. If you have any ideas for a future show or you'd like to be a guest, please send me a message. You can reach me through the website patientsatrisk.com. If you're a physician and you'd like to learn more about getting involved in our mission, which is advocating for physician-led care and truth and transparency among healthcare practitioners, then please join our group. It's called Physicians for Patient Protection. You can learn more at our website, physiciansforpatientprotection.org. Thanks so much, and I'll see you on the next podcast.